What if you could solve a really complex case of kidney dysfunction, starting with just one single abnormal lab value? Well, in this explainer, we're going to build a powerful diagnostic framework that turns you into a clinical detective, ready to follow the clues all the way to the right diagnosis. First things first, let's define our central clue, azotemia. Now, this isn't a disease itself, it's more like a signpost. It's telling us that waste products, specifically nitrogenous ones like BUN and creatinine, are building up in the blood. And why does that happen? Because the kidney's tiny filters, the glomeruli, aren't working as well as they should, which is basically a direct reflection of a falling GFR. So, you see this on a lab report, and the immediate question is, okay, what's causing this? It can feel pretty overwhelming, right? There are dozens of potential culprits. But the key isn't to just start guessing. It's to have a system, a method, just like any good detective, to follow the evidence and get to the root cause. So here's our 5-step game plan. We'll start with the case itself. Then we'll localize the problem. Is it before, in, or after the kidney? Then we'll uncover some clues hidden in the urine, decode the urine volume, and finally put it all together into a diagnostic approach you can use every single time. All right, let's dive in. Think of azotemia as the first call you get on a case. You know something is wrong, but you have no idea who, what, or where. Our job is to start gathering evidence to crack this thing wide open. So our first big move is to figure out the location of the problem. You can break down almost any cause of acute kidney injury into one of 3 buckets. Is it pre-renal, a low flow issue before the blood even gets to the kidneys? Is it intrinsic, a broken filter problem within the kidney tissue itself? Or is it post-renal, a blocked pipe obstruction somewhere after the kidneys? Now, this flowchart might look a little complicated, but just think of it as your diagnostic map. Don't worry about every single box right now. Just look at the very first decision at the top. It tells us to get a urinalysis and a renal ultrasound. Why? Because that ultrasound can immediately spot a swollen kidney, hydronephrosis, which is a dead giveaway for a post-renal blocked pipe problem. If the ultrasound is clear, then we follow the other branches to figure out if we're dealing with a pre-renal or intrinsic cause. And this is where the story gets really, really interesting. Just look at the differences here. In a pre-renal state, the kidney itself is actually healthy. It's just not getting enough blood flow. So what does it do? It does its job perfectly. It furiously tries to hold on to every last drop of volume by reabsorbing sodium and water. That gives you a really low fractional excretion of sodium, or FeNA, and super concentrated urine. But in intrinsic failure, the kidney's machinery is actually broken. The tubules can't reabsorb sodium, so it just gets wasted into the urine. That gives you a high FeNA and dilute urine. You see, these numbers aren't just data points. They're telling you a story about the health of the kidney itself. All right, moving on. Let's look at how the urine itself is basically a liquid biopsy of the kidney. It's got direct evidence of what's going on inside, whether it's protein, blood, or specific kinds of cells and casts. So if we find proteinuria, excess protein, this flowchart shows us exactly what to do. The very first step, quantify it. Are we talking about a little bit of protein, or is it in the nephrotic range, which is a huge loss, over 3.5 grams a day? That single piece of information immediately narrows down our list of suspects, and it points us directly toward diseases that affect the glomerulus, the kidney's main filter. And you know what? The same logic applies to hematuria, or blood in the urine. Finding blood kicks off a whole new line of investigation. Is it coming from a simple infection, a painful kidney stone, or is it something more serious, like a glomerular disease or even a malignancy? This map helps us navigate the workup, helping us decide when we need to order imaging or maybe even more invasive procedures like a cystoscopy or a biopsy to find the source of the bleeding. Sometimes the most powerful clue is also the simplest one. Just measuring how much urine a patient makes in 24 hours can tell us a massive amount about not just their kidney function, but their body's entire water balance. Okay, so on one end of the spectrum, you have oliguria and anuria. An output of less than 400 mLs a day, that's a major red flag. It means the kidneys aren't even making enough urine to clear the body's daily waste. And complete anuria, that's a true medical emergency. It often signals a total blockage or some kind of vascular catastrophe. Then, on the complete opposite end, you've got polyuria, making more than 3 liters of urine a day. And this isn't just about drinking a lot of water. It really boils down to two basic mechanisms. Either you're getting rid of too much solute, like all the glucose and uncontrolled diabetes, or you're losing way too much free water, which points to a problem with antidiuretic hormone. And this flowchart just lays it all out beautifully. The very first step is checking the urine osmolality. If it's low, meaning the urine is super dilute, that tells us the body is losing too much free water. From there, a water deprivation test can help us figure out the two main culprits. Is it central diabetes insipidus, where the brain isn't sending the right signal, or nephrogenic diabetes insipidus, where the kidney isn't listening to the signal? It's just a perfectly logical pathway. Okay, so we've looked at all the individual clues. Now let's assemble them into that clear, repeatable framework that you can take with you and use in your own clinical practice. Here it is in 4 simple steps. Step 1, identify the core problem, the azotemia. Step 2, localize it. Is it pre, intrinsic, or post-renal? Step 3, interrogate the urine for specific clues, like protein and blood. And step 4, assess the urine volume. By following this sequence every time, you build your case methodically, and you won't miss critical pieces of information. So why does mastering this framework really matter? Honestly, it's about more than just getting the right answer on a test. It's about being a safer, more confident clinician. It gives you a structured way to think that makes sure you're thorough and efficient every single time you face a patient with kidney dysfunction. It transforms that feeling of uncertainty into a clear plan of action.